See here, this is the axilla. This is the axilla. So the breast is divided into 4 quadrants and the nipple areolar complex, NAC, nipple areolar complex. So 5 regions total. So majority of the breast cancer is here only, upper outer, and inner and lower. This is the least chance of having malignancy. Okay, most common site and least common site, upper outer, lower inner. Okay, why is it so?
Upper outer has more glandular tissue.
Yeah, upper outer has more glandular tissue than the lower inner side. Okay, so it is more chance of having malignancy. 60% malignancy arise here only. Okay, so most common in the world in females. What is the most common cancer in world in the females? In India,
breast
urban
cancer.
India, rural India.
In the world is breast cancer, urban India is breast cancer, rural is cervical cancer.
Yeah, rural is cervical, and world it is breast. And recently there is some ambiguity here. Some journals are suggesting lung cancer as the commonest cancer, and some journals are suggesting breast. We don't know what is the exact answer for this, but for India, say in urban it is breast and rural it is cervical. Okay. Yeah, and cause of death is how a breast cancer patient will die. The most common cause of death is to metastasis. Okay, and second most common cause of death is pulmonary complications. This is the second most common cause of death. Okay, and this we'll discuss. The most common site of metastasis. Anybody? This no, we'll discuss. But what is the most common site of metastasis? Where will the breast cancer metastasize to most commonly?
Axillary.
Yeah, axillary lymph nodes. Okay, then which bone? On bone it goes. Which bone?
Is it clavicle?
No.
Sternum.
Sorry?
Lymphatic.
No. It goes to the vertebra. Okay, which vertebra? Lumbar vertebra mostly. Cervical and lumbar vertebra. Okay. So this is just this picture from pathology Robbins. This is the breast. This is the muscle underlying pectoralis. This is the glandular tissue and the stromal tissue. Two types of tissues are there here: the gland and the stroma. Okay. So the origin of breast cancer, it is in TDLU. We call it as terminal ductal lobular unit. We call it as TDLU. That is the origin here. The terminal ducts in the lobule, it's the terminal duct. Here the breast cancer originates, and it either goes front or back or some. The mass originates in the terminal ductal lobular unit. Okay. So some signs, we'll discuss about some signs of.
There was a question that I wanted to ask you regarding the Birard score. So I remember there was a question in FMGE that I saw some time back. So depending upon the Birard score, actually you recommend whether to do a mammography or FNSC. So would you be able to tell us about those?
Yeah, that is there actually. This. See here. If you find it is suspicious, okay, or highly suggestive of malignancy, then you need a tissue diagnosis. Tissue diagnosis is you need an FNAC or a core cut. Okay, either in 4 or 5 only, you need a tissue diagnosis or core cut. In otherwise, if it is routine screening, no need to do a tissue diagnosis. Two also.
Question. My question is, like, for example, if we have like negative, so negative, or if it is benign, that is 1 or 2, right? And
yeah, 1 or 2
as well. So in 1 or 2, we will be doing an yearly mammogram. Am I correct?
Yeah, routine screening means yearly mammogram. Yes.
Yearly mammogram. And
yes.
If we have probably benign, then short-term follow-up. So basically, within 6 months, we would be doing a mammogram or just a clinical examination.
Yeah, clinical examination. At 6 months, clinical examination, yearly mammogram. If
yearly
you
mammogram
have any pathology at 6 months, then you do a 6-monthly mammogram.
Okay.
If
Otherwise,
you
we will
don't find,
do an
don't find
examination
any
and
change,
yearly
yeah,
mammogram.
yearly mammogram. If you don't find any change in the lesion, then you can continue with yearly mammogram only. No need to do a 6-monthly mammogram because it has its own side effects, radiation and.
Okay. And if it's suspicious, then it's straight away we are
Definitely,
going to do
yeah.
a
If it is
biopsy.
suspicious, definitely tissue diagnosis.
All right. Okay, got it. Thank you.
Yeah. Okay. So, see here, these are the 3 signs, important signs: retraction of nipple, dimpling and puckering of skin, purity orange. I think you have seen this when presenting for the case in your final year examinations. So, this is the breast tissue cross section. Okay. So, this is the duct. This is the nipple. So, there are subalveolar ducts. Okay. There is some ducts here, subalveolar ducts, number 1. And there are some ligaments, Cooper's ligaments from the skin directly into the muscle. They are known as Cooper's ligaments. And there are some subdermal lymphatics here, lymphatics. There are subdermal lymphatics, 3. If one will get infiltrated with malignancy, if one, like subalveolar ducts or these lactiferous ducts, if they get infiltrated with malignancy, see, there is a strand like this. Suppose it's a strand. If there is malignancy, it is pulling off. So the nipple will be retracted back. Okay. So if retraction of nipple is due to subareolar duct, that is the first thing. Dimpling and puckering of the skin is due to Cooper's ligament infiltration. In the same way, there are, imagine ropes are tied from breast to the muscle. And once you pull the rope, what will happen? In the skin, there will be some dimpling or puckering. Dimpling or puckering, almost the same. So it is due to infiltration of Cooper's ligament. Cooper's ligament. And finally, there is subdermal lymphatics are there. Subdermal lymphatics. These lymphatics, if they are blocked, there will be purity orange appearance. What is this purity orange appearance? Anybody?
Like an orange skin.
Yeah, like a skin of the orange. It will be the same, like a skin of the orange. That is, if this is there, then what is the indication that the lymphatics are involved? Subdermal lymphatics, which are just behind the skin. Subdermal lymphatics are involved. Okay. If these are involved, you will get that edematous appearance. Okay, you can see in this picture. This is the purity and the classic purity orange appearance. Purity orange appearance. Okay. Okay. So if this is clear, now we can move on to the risk factors, etiology and risk factors. Till now, okay, clear?
Okay, sir. Yeah.
Okay. So risk factors. All the following are risk factors for development of cancer breast, except the answer is highlighted here. But why is it so? Just read the question for 2 minutes. The answer is multiparity and prolonged life is not a risk factor. I mean, all the following are risk factors for development of breast cancer, except. So, which is not a risk factor? That is a simple question. So, just can anybody tell me the answer? Why is it so?
Hormones, estrogen, progesterone.
So, see, BRCA1 and BRCA2 genetic mutations, genetic factors. BRCA1 and BRCA2, BRCA1, BRCA2. Okay, these two. Yesterday, in which cancer we are discussing about chromosome 3?
RCC.
Sorry?
RCC.
Yeah, RCC. What is the gene there? Chromosome 3. What is the gene I told you?
VHL.
VHL, Van Hippel-Lindau. Very good. So here in the same way, in breast cancer, we have 2 genes, BRCA1, BRCA2. If both are present, or at least one is present, there is high chance that the patient will develop malignancy. So BRCA1 gene mutation is a risk factor. History of contralateral breast cancer. A patient has breast cancer on one side, there is high chance that she will develop breast cancer on the other side also. So history of contralateral breast carcinoma, it is also a risk factor. Early age of menarche and multiparity. So see, suppose 2 females are there. One female attains the menarche at the age of 12 years and one female attains the menarche at 15 years, suppose. Okay. So 12 years of age till 45. Suppose both are attaining menopause at 45. So the cycle she is exposed is more in this female. So the hormonal imbalances are more in this female than this lady. Okay, so early age of menarche is a risk factor. Okay, and multiparity. Sorry, this is not multiparity. This is nulliparity. Early age of menarche and nulliparity is a risk factor. Multiparity and prolonged lactation are protective factors, because once she is parous or she is in lactating period, there will be no hormonal imbalances at the time, right? Yes, no?
Yeah, hyperestrogenism is, a state of hyperestrogenism, such as early menarche, late menopause, nulliparity, and so these are the factors which are
These are the
considered.
factors. Early menarche, late menopause, and nulliparity. The woman will be exposed to multiple hormonal cycles. That's what I wanted to convey. So, late menarche, late menarche, early menopause, and this one, multiparity, prolonged lactation are some protective factors actually. Is it clear?
Yeah, that's clear, sir. But these days, girls attain puberty at the age of 10 or even 12, right? Like, that's increasing.
So that's why breast cancer is increasing nowadays.
Oh, okay.
Even young girls also, like almost 10-15 years back, people who used to get breast cancer like 45-50, those used to be our routine patients. But nowadays, even at 30-35, we are seeing many breast cancers. Okay, and the pickup rate also has increased definitely because of this modern investigations and all. Earlier used to get big masses. Okay, almost like it used to get metastasis. Almost if we see 3 patients, 2 patients will have metastasis to other organs. Okay, they will not be aware of breast cancer also because of nowadays these awareness camps and these multiple investigations being done. So we are picking some early lesions, and we are doing some breast conservation therapy only. No need to go for radical surgeries at early stages, right? If you pick up a small lesion, we can just do a breast conservation surgery.
Okay, sir.
Okay. Yeah, this is increasing. Definitely, the trend is an increasing trend only. Even many lifestyle disease like hypertension. Earlier days when you were small and earlier some 10-15 years back, hypertension used to be a disease of 40 plus, 45 plus at least. Okay.
Yes, sir.
But nowadays 25 is the cutoff. Even 25 to 35, many almost we'll just examine whenever you take a history or something like that. Almost after 25 years, like out of 10, you can tell 6 people are having hypertension, essential hypertension.
All right, sir.
In some days before, if an young fellow develops hypertension, we used to do multiple investigations, like to do a renal scan. We'll do an ultrasound. We'll do a renal artery hypertension because that is rare. Will not essential hypertension is without any reason. You know that, right? Medicine. So
yes, sir.
Nowadays these essential hypertension cases are on rise. These are our lifestyle diseases.
Okay, sir.
So just to summarize the risk factors, it is BRCA1 and BRCA2, history of contralateral breast cancer, early age of menarche and nulliparity, and also early menopause.
Late menopause. Yeah, late menopause. See, that's what. Early menarche, late menopause. She is exposed to multiple cycles, right? Early menopause is a little bit protective factor. Cycles are over. Early menopause.
Okay, sir.
You understand the
concept? Yeah, estrogen actually has a positive effect on the breast cells. And this is the reason why more cycles you go through it, higher the risk factors of breast cancer it is.
So multiparity and lactation, the patient is not exposed to hormones in this period. Multiparity, if she is conceived, so there will be hormonal break. Even during lactation period also, there will be no cycles, menstrual cycles. So this is a protective period. Okay.
So just out of curiosity, I'm asking you this. Aren't people attaining menopause at an early age these days
These days?
Aren't women attaining menopause at an early age these days?
Yeah, definitely. They're attaining, and most of the times they're undergoing hysterectomies also, because some fibroid or some endometriosis is there. Like earlier days, people used to suffer and they used to take some medicines and they used to quit it. But nowadays, if suppose a 35-year-old lady has a small fibroid also, she will go for hysterectomy directly. So obviously she is going into menopause, right?
Yes.
Yeah. So this trend also is increasing. Hysterectomy, getting done. Hysterectomies is the most number of surgery after cesarean sections. Gynecologists perform hysterectomy is the maximum number of cases. Even a small fibroid, even a endometriosis, even like it's not wrong to do also. I'm just not pointing out someone, but these cases are also increasing. I'm telling. People are not ready to suffer now. They want the best treatment, and they think that once they are conceived and after 35-40 years, they want to get rid of their uterus so that they'll not suffer with fibroid or this endometriosis, DUB, dysfunctional uterine bleeding. These cases are also increasing.
Okay, so this is more like a safe mechanism, right? Or
Like
it might have
has
adverse
its own
effects.
complications, right?
Oh,
this hysterectomy,
okay.
doing hysterectomy, and not only hysterectomy, they'll get rid of ovaries also. So they will badly hamper their bone health. Okay. Estrogen is little cardioprotective. So once you knock out estrogen, so the woman, see, men and women are there, but men suffer with more chance of cardio events like MI and all. Why? Because estrogen is little protective, cardiovascular health and bone health. So once you knock off this, like do a hysterectomy and ovarectomy, so they are equally getting risk of heart diseases and osteoporosis. These type of diseases will increase. At 35-40, if they get hysterectomy done, by 50 or 55, they will get these diseases.
All right, sir. Thank you so much, sir.
So, which one predisposes to breast cancer? See, now one part of risk factors we covered. The other part of risk factors are risk factors number 2 is, see, so many people suppose out of 100 females, almost 20 to 30 of them have some breast lesion, some benign breast lesion like adenosis, fibrosis, mastitis. Some lesion will be there. These are all not malignant. These are all not, they are all not pre-malignant also. They will not turn into malignant except this atypical hyperplasia. See, one more thing, whenever this atypical is there, typical is normal, general findings. Atypical is something altered, some alteration is there. Whenever there is this atypical hyperplasia, what is hyperplasia?
Increase in number of cells.
Whenever there is this atypical hyperplasia, that is, number of cells are increased, but it is not in the typical way, that is not in the normal way, then there is high chance that this patient will this lesion will turn into malignancy. Okay. So risk factors we all have discussed. Age, obviously, as age increases, there is early menarche, late menopause, nulliparity, maternal age at first birth, obesity, alcohol, family history, hormone replacement therapy, radiation. These are all risk factors. And earlier there is a misconception that oral contraceptive pills, OCPs, have increased risk, but nowadays it's proven that there is no risk with OC pills. Okay, this is also a question they'll ask you. Which of the following is not a risk factor? Smoking, alcohol, obesity, and OC pills. So OC pills has no increased risk with breast cancer.
And smoking as well, right?
Which one?
Smoking also is not a risk factor.
Alcohol, yeah. Yes.
Obesity is, but smoking is not.
Yeah. So there is slightly increased risk and moderately increased. This is about the lesions I told you, right? So hyperplasia. Whenever there is hyperplasia, there is increased risk. It is increase the number of cells. But atypical hyperplasia is there, then it is 5 times increase in risk. Atypical hyperplasia. So the word is important. Whenever you find atypical hyperplasia, mark it for predisposition factors of breast cancer. Okay. Atypical hyperplasia. It is not in the usual way.